And thank you for joining the Patient-Centered Primary Care Collaborative today for the second webinar in our three-part cancer care series. My name is Dana Bright, and I'm the Manager for Medical Home Initiatives at the American Academy of Pediatrics, and I will be serving as your moderator for today's webinar. With support from the American Cancer Society, the PCPCC's Center for Patients, Families, and Consumers has developed 3 fact sheets and checklists to enable patients with cancer to better communicate with their primary care and oncology teams during initial diagnosis, during treatment, and as survivors of cancer. Today's webinar, Working with Care Teams During Treatment, will feature Dr. Carmelita Escalante, a professor and department chair of General Internal Medicine, as well as Lyle Green, Associate Vice President of Physician Relations at MD Anderson Cancer Center in Houston, Texas. You can access the checklist from PCPCC's website at pcpcc.org. In addition, the recording and slides for this webinar will be archived on PCPCC's website starting tomorrow. And you can find all of PCPCC's archived webinars under the Resources tab along the top of the web page. So throughout the webinar today, feel free to ask questions using the drop-down box on your screen. We will be keeping all phone lines muted to avoid any background noise. But as I mentioned, all throughout the webinar, you can use that drop-down box on your screen to type in your questions and to submit those. And when we're finished with the formal presentation slides, I will be posing these questions to Dr. Escalante and to Lyle. So now I would like to introduce our 2 speakers briefly. Dr. Carmelita Escalante is a primary care physician and leads the Department of General Internal Medicine at MD Anderson Cancer Center, where she has successfully built a number of clinical programs, developed a research program, and developed the first cancer-related fatigue clinic in the country. Dr. Escalante is a longtime advocate and mentor for faculty in leadership building and promoting collaborative and collegial teams in the workplace. Also presenting today is Lyle Green, Associate Vice President of Physician Relations, and he provides leadership for enhancing physician access, communications, and engagement strategies at MD Anderson. Most notably, Lyle provided the initial vision for and led the design, development, and implementation of the My MD Anderson Physician Portal, which provides referring physicians with a highly customized online referral process and secure web-based access to their referred patients' medical record information. So now I'd like to turn it over to our 2 speakers for today's presentation.
Good morning, and we both thank you very much. We're going to be going back and forth, changing off as we go through the presentation. What I'd like to do is to first start with the next slide. There we go. Oops. This demonstrates, and it's from the American Cancer Society's website, the various new cancers that are distributed throughout the states. This is a rough estimate. It doesn't include skin cells such as basal cell and squamous cell, but gives us an idea of the number of cancers which we anticipate in FY13 to be approximately over 1.5 million new cases. So some background as we move through this: over 500,000 Americans will die of cancer in this year, and that comes up to about 1,600 a day. As most people know, that 2 of 3 people diagnosed with cancer will survive at least 5 years. And this is growing as we develop better cancer strategies and therapies to cure patients of cancer as they are diagnosed with cancer, and it becomes more of a comorbidity, long-term chronic disease state for some patients that are not cured. And very commonly, cancer is diagnosed in the older patient population. So as I thought about this process in the issues for patients with active treatment, when we take care of patients with internal medicine issues, we have to think of the various problems. Patients, as we know, are older. They already have pre-existing diseases such as hypertension, diabetes, coronary diseases, and other chronic conditions that are totally unrelated to cancer but are present. The patients undergo a number of different procedures during their active treatment, and they need adjustments to these medications. So we have, for example, patients losing weight, and they may, many times they either reduce or entirely eliminate their antihypertensive or diabetic medications depending on the weight loss. On the other hand, we may give them agents such as the tyrosine kinase inhibitors for treatment that induces hypertension. And so adjustments to those medications again have to be made. And often we diagnose new comorbidities that may not be present at initiation of cancer treatment or were undiagnosed prior, because some patients, this may be their introduction into the healthcare system when they develop a cancer and have not been diagnosed with underlying hypertension that may have been present, or diabetes, or other comorbidities. There are also other medical issues that we have to consider that are related to cancer. An example, pericardial effusion develops secondary to the malignancy, or superior vena cava syndrome develops secondary to the malignancy. With the pericardial effusion, the effusion may not only be present, but then they develop a tamponade that requires medical treatment. The medical issues also may be related to the treatment, such as the steroids that we often give that cause hyperglycemia and, in some cases, full-fledged diabetes. The TKI inhibitor use, as I previously noted, that causes hypertension, at least while on treatment. It is definitely important that the PCPs are involved during cancer treatment. And there are various ways that when patients develop cancer, have relationships with their PCP. For some patients, there is already an established relationship, and this internist or family practitioner may have diagnosed the malignancy. There may be additional patient and family support, and it's important because there is continued management of existing comorbidities necessary. Also, the PCP will help with medical issues related to the cancer or cancer treatment. And this may depend upon the level of comfort that that primary care physician has with managing these while the patient undergoes cancer treatment. It also may be dependent on the site or how far from the cancer treatment site the PCP and the patient lives. Sometimes there's a lot of distance and travel, and the patient may be staying at another location in a larger city where the comprehensive cancer center or the cancer treatment area may be, and that is away from the primary care physician. And there may be oncology collaboration necessary to manage the internal medicine issues. As I developed these slides, we have to think about the types of management strategies that cancer patients may have or need during active treatment. So I put this into 3 buckets. Some patients are co-managed with the oncologist during cancer treatment. So you have the patient as the primary care physician, and they have their oncologist, and things flow back and forth in a regular pace depending upon the issue. So the patient is actively seeing both physicians, one focusing primarily on the cancer and one focusing primarily on the internal medicine issues. You may have another form where the oncologist takes over all the medical issues, and basically the PCP and or the patient defer all the issues to the oncologist. Some oncologists may be very comfortable in managing these, so they manage issues related to the hypertension, the diabetes, other new internal medicine concerns that may be coming up as the patient goes along the trajectory of treatment. And then sometimes we encounter totally independent management, where the PCP and the oncologist may not be communicating that much. This may be in areas where the patient has separate care in different locations where it's harder for that communication issues to take place. So you have a PCP managing internal medicine issues without much input from the oncologist, and you have the oncologist basically managing the oncology issues without much input from the PCP, or let's say very little input. Do you want to take over this part?
Yeah, thanks, Dr. Escalante. I think one of the things that's interesting, from our perspective as a physician relations team and working with both primary care physicians, oncologists, and other specialists outside of a place like an MD Anderson is, the referral pathways or the coordination of care pathways, if we want to call it that, get very complicated and sometimes difficult to understand, and particularly in making sure that for a particular cancer patient, we know who are the particular doctors that are involved with that patient's care. And what I mean by that, and probably the simplest example is, oftentimes when we're working with primary care doctors outside the institution here, we will encounter some physicians who will say, I suspect my patient has cancer, or we've diagnosed them with cancer and we want the Comprehensive Cancer Center to just take care of the patient. And I, as a primary care practice, may not be or want to be involved going forward. Then we have other cases in terms of we're working and coordinating that with a community oncologist or a non-comprehensive cancer center oncologist. And as we'll talk in a few moments, the communication issues around all of that, whether it's the referral of the patient on the front end, keeping the primary care physician, the oncologist for that patient in the community up to date with the status of their treatment, as well as on into when it's time for that patient, they've completed their treatment, their active treatment, and they're going back to their home community. Who are the physicians that will be taking care of that patient that we need to communicate with, provide ongoing instructions as that patient is now in a survivorship mode. So again, as you can see from the slide, those pathways, how patients get to their primary care physician and onto a place like a community general oncologist or a comprehensive cancer center, get tricky. And we have mechanisms and processes in place to identify all of this, but it's very challenging on the people, process, and even the technology side to get it right 100% of the time. And then as we're dealing with issues in healthcare reform today, people's primary care physicians are changing or more likely to change quite a bit in the near term. So making sure we know who all of the patients involved providers are, if you will, is critical.
So as Lyle said, this just demonstrates 3 different scenarios with a rural area where the PCP may be the the only physician in that area, to a community area where there may be more subspecialist physicians available, to the Comprehensive Cancer Center where there are oncologists that subspecialize in one particular area of cancer, and internists that have expertise in dealing with just cancer patients. The red lines were demonstrating just the route from the PCP to others, and the yellow lines were demonstrating from oncologist referral patterns. And this is just some examples. This is not totally all the various pathways that may happen. So the options during treatment, as we tried to demonstrate from the previous figure, some patients have all their cancer treatment close to home. Some patients have some treatment at home and some treatment away from home. And at our center, we do various things. For some patients may come in and get the beginning of a treatment, and there is a discussion between the subspecialty oncologist and the general oncologist back in their home area, and the patient may get several cycles back home and just come in for restaging and for a treatment once every 6 months or every 3 to 4 months. So there's a shared collaborative treatment pathway. And then some patients decide to have all their treatments away from home at a distant site, such as a comprehensive cancer center. And when they do that, that also requires that everything, the whole package, not only the cancer, but the internal medicine issues as well, are taken care of while they're away. At a comprehensive cancer center such as MD Anderson, we have other subspecialty groups in general internal medicine as well as in all the other medical subspecialties, cardiology, infectious disease, that can manage these patients while they're away from home if they need that kind of care. So I put in a couple of cases just to give an example and make it a little bit more realistic. So we have Miss A, a 55-year-old lady that has a very early stage breast cancer, a T1C NMO left breast cancer. She self-palpated this breast mass and saw her PCP, who arranged for a biopsy and then referred her to our center. Now, this particular lady lives about 150 miles away, 2, 3, 4-hour drive depending on traffic and everything else. But she also has these other medical conditions that are very common, especially in patients in their 50s and older. She has diabetes, hypertension, hyperlipidemia, and she underwent a left mastectomy and axillary node dissection. She had adjuvant chemo, followed by radiation, and a full year of Herceptin. So she has a local PCP that's managing her comorbidities. During her treatment phase, she had her medical issues co-managed with the internist at MD Anderson and her primary care physician back home. So there was a shared internal medicine team. And with the comorbidities and the radiation to the left chest, we know as she becomes more of a survivor, she is going to need careful risk management for coronary disease with that radiation to the chest. So she'll continually need close and careful management of her underlying risk factors. And she was a very early stage, so she likely will be a survivor, do well, live at home. So her PCP will need to continually manage those comorbidities as she goes into, completes her treatment and goes into the survivorship arena. A second case as a scenario is a 65-year-old man with castration-resistant prostate cancer and bone metastases. This patient received numerous regimens in palliative radiation, and this is one of my patients. He developed a pulmonary embolus while on treatment and has been under treatment of that with anticoagulants, and he lives close by to our cancer center, is a Houston native. He is managed by internal medicine at our center. He has hypertension, hyperlipidemia, obesity. He's on low molecular weight heparin for his pulmonary embolism, and because he has continued metastatic disease, he has continued on this for the last couple of years. And he continues to receive active cancer treatment. He is working full-time as a chemist. And so what's going to be important is that he be followed. In this treatment management, he is being followed primarily by the internist at MD Anderson. His oncologist is here, and it's convenient for him. He feels that it helps him to have one place where he sees his oncologist and his internist together. So he has not been transitioned out to the community. But I think that Lyle has mentioned before, the success of medical care of patients during active treatment comes down to communication.
Yeah, and I think Dr. Escalante and to the attendees, I've been involved in physician relations here for about 17 years now, and one of the, actually the two most important issues, critical issues that we face in working with doctors who refer patients here, number one is the communication about the patient care, and number two is the referral process and how easy it is to access the organization for their patients. And all of that is supported by communication as well. So in terms of those types of issues, and we'll talk about the challenges, and I would say challenges in communication during cancer treatment, what we typically hear from the doctors we work with is the timeliness of the communication, the completeness of the communication that I receive, and most of that involves, for example, traditionally we would print and mail medical record information, patient reports that our faculty would dictate and transcribe, but with the regular mail, some of those reports could take several weeks to get to the primary care physician's practice, and we're not sure how long after that it might be before that physician would actually see that report and know what was going on with their patient while they were under active treatment. Then there's the completeness issue. That's one report, but it's not anywhere near the comprehensive medical record. And certainly the primary care physician is not able to follow their patient status in real time. So all of these issues that you see and challenges that you see primarily focus around the communication issues. Another one, the patients want all treatment from the cancer center and their oncologist. We often encounter patients who, once they're here, they want to stay for everything, including their non-oncology care. And sometimes we don't and are not able to learn who their primary care physician is. And then beyond that, to take it one step further, sometimes we'll have a patient who will say, I don't want communication to go out to a particular doctor, or they may not know I'm here, and those are some different issues in terms of communication. And then the physician is upset, thinking we're not communicating when we don't really know who they are. Another challenge we have in communications that's not listed here is, in this day and age, you have the issue of self-referral, where patients are driving some of those decisions more so than maybe in the past. And a lot of times, again, when a patient would self-refer to a place like MD Anderson, we may or may not know who their primary care doctor is. And again, if we don't know that, then we're not able to support the communication process. So I think in terms of looking at solutions and how do we overcome some of these challenges, a couple things that come to mind. One is, obviously there's a need for ongoing education, and I would say some of that is medical education in terms of how to support and take care of the patient in a survivorship situation after their treatment, as well as during their treatment. But then also education about how do we get adequate communication and medical record access to both primary care physicians as well as other specialists who are involved in the patient's care. Telemedicine is one example, but I think probably generally that's not terribly widespread. A lot of challenges in access, I think, there. But when we get down to communication, my perspective nowadays is verbal is challenging with telephones. Written is even more challenging and extremely expensive. And as I mentioned before, you don't have the timeliness and completeness there. But when we get into things like leveraging technology, I think on the next slide we can talk a little bit more. Okay, we're skipping this. Whoop, there we go. Sorry about that. Just want to talk briefly about some of the things we've done here at MD Anderson in response to those communication challenges of timeliness and completeness. We go back about 9 years. We launched what we call the MD Anderson Physician Portal in early 2005, and that was in response to physician issues and challenges with communication and referral process. And long story short, today, 9 years later, we have approximately 13,000 doctors in 113 countries who have registered on the portal and have secure web-based access to both refer patients as well as access their essentially complete medical record minus several restricted document types. And the information that's available in the medical record is available immediately when that patient document is electronically signed by the MD Anderson faculty member. Lab results, for example, are available immediately when they are finalized. So you have the issue of timeliness as well as completeness has been addressed there. Our challenge here on the MD Anderson side is that we only have the 13,000 physicians using the portal. We have approximately another 100,000 doctors of various specialties who are associated with patients under care here. And those patients may be referring doctors, they may be primary care physicians, as well as other physician specialties who may be involved in that patient's care in some way, shape, or form. So we have challenges on that end in getting everyone using the portal, being comfortable with the technology. And so to do that, I'll cycle a little bit backwards. When we talk about physician microsites and portal ROI, what I'm really getting at there is the physician microsite is a dedicated site, and the URL is physicianrelations.org. It's an MD Anderson site, but it's dedicated to provide access and the functions that the physician community needs in taking care of their cancer patients and accessing the institution, and that includes our faculty directory. So physicians outside the organization can look up MD Anderson faculty members, read their bios, see their publications, their clinical and research interests. But when we get into ROI, what we're really getting at, to us, the return on that investment is we're doing a better job in terms of patient care coordination, clinical communications, and accessing, coordinating care for those cancer patients who come here. And I'll kind of stop there in terms of talking about the portal itself, and happy as we get into questions. If there are more detailed questions that people want to ask, we'll certainly want to cover those.
So I'll go back a couple slides since we wanted you to see what this looked like. So as Lyle said, these are some of the challenges. As he mentioned before, handoffs, and this all goes to the number of physicians that may be taking care of the patient. And then you have the various ways that Lyle just briefly went over. And then we also want to educate patient and families that may be away from their oncology or primary care physicians about signs and symptoms to report. And maybe we do that through symposiums, webinars, websites, or support groups. And we've done various different things, at least at our center, in trying to make sure patients and families knew what to expect and had support from various different types of aspects. And then lastly, this is our opportunities for success. This is what we want to happen. We want our patients to receive state-of-art oncology care wherever they are. They should be able to get the best And they should be able to participate in cutting-edge clinical research that helps them and may help future cancer patients. We also want to better educate our patients, our families, our providers, all of our trainees on internal medicine and primary care issues in active cancer patients. And we want support for patients and families so that they are comfortable wherever they may be and confident wherever they may be in all of their healthcare providers, whether they're in a rural area, in a community setting, or in a comprehensive cancer center, that they feel that they're getting the best treatment available during their active cancer therapy. And that's our last slide, so we will stop and available for questions.
Great, fantastic. Thanks so much. This is Dana Bright again. Just want to thank Dr. Escalante and Lyle for their presentation. And to remind everybody on the webinar that you should see a question box or a drop-down box on your screen in which you can type in and submit your questions that we can then pose to our speakers. So this is Dana again. I do have one question to start. Dr. Escalante, you mentioned earlier that there are different types of management, be it co-management, the oncologist managing all of the care, or the oncologist and PCP being independent of one another. Have you found that there are any differing outcomes depending on the type of management approach and outcomes for the patient?
Well, I don't have any firm data. I think it depends on, some of it is variable depending on how big the internal medicine issue burden is and how competent the provider is. I think the more if you're a subspecialist and you commonly manage internal medicine issues, you're probably more adept. When you start getting very subspecialized, for example, our oncologists at MD Anderson, many times they defer the internal medicine issues to us because they don't do it as much. I particularly like some of the co-management because, especially even within our center, we co-manage. It may be co-management within a center, but it takes a team of experts because medicine now is so complex that it's very difficult for a physician to keep up in every single area of medicine, being the oncology expert, being the internal medicine expert, or whatever else the patient may require. So I think there are some variables for a patient that has very well-controlled hypertension and may be on one antihypertensive and has no other medical issues. An oncologist may be comfortable, or the PCP and the oncologist may be able to do it independently. But for a very complex patient that has multiple medical issues, some induced by the cancer or cancer treatment, it often takes a collaborative team.
Great, thank you so much. And this may be a somewhat related question that has come in. Have you developed any standardization to easily identify each patient's management strategy?
Okay, tell me a little bit more about what you mean for their medical issues?
Well, I'm going to have to read into this myself, the question that has come in. But again, it sounds like if there is any sort of standardization process to go about perhaps identifying which management strategy is best for which patient.
Well, often if I have a patient that comes to me in my clinic, it depends. Some of it I talk about with the patient. How long are you going to be here? Do you have an internist or a family practitioner? Because some patients don't really have a physician. Others have physicians that are very involved. Are you going to get your cancer treatment here? For a patient that may be going back, several hours away or across the country and has diabetes, then I may treat them while they're here and defer to their internist back home. And the patient and I would discuss that, as well as I may discuss it with the oncologist to come up with a plan of how we're going to do this. For a patient that may be getting radiation to the chest for either head, neck, or gastric cancer or lymphoma, where we know they're going to may need a feeding tube and have difficulty eating and are going to be here, I will closely manage those patients. If a patient lives locally and has an internist, it depends upon the patient and how comfortable they feel and how comfortable the internists feel. And so I think it's an approach that I often discussed with the patient and their family, as well as with the oncologist here, and sometimes with the referral, either PCP or oncologist, depending if the patient is going to go back home and there are very specifics that will need to be, done at home. They're on a steroid taper and their glucoses may be going down and they're going to need a close eye. Then, whether I communicate that through the patient or directly with the PCP is something that we will come up together. I'm hoping I answered that question.
I think so. Thank you so much. And another question has come in, and this relates to, again, that management either between the oncology team or the internal medicine team. How are chemotherapy-related side effect issues handled?
Well, it's variable, but many times we in the Department of General Internal Medicine may end up handling some of those. For example, sometimes we do have a pain management service, but if I'm seeing a patient for other medical issues and their pain control needs some adjustment, and sometimes the oncologist is managing the pain with it, we may make recommendations for the patient because we want them not to be in pain, or nausea or other symptoms. And many times the patient comes back to the internist for refills on all their meds, regardless if the oncologist prescribed the antiemetic or someone else prescribed the Lyrica for neuropathy. They're seeing us for medical issues and they're running out of meds, and it's easier sometimes for them to come to kind of their primary care physician in the center to do that for them.
Thanks so much. We have a question that relates to the involvement of nurses in the coordination of care, particularly when the PCP may not be as engaged in the process as that person could be. And how or what suggestions might you have then for nurses and how they can stress the importance of the engagement of the PCP?
Well, I think it's very important that the nurses that work with the PCP or mid-levels, sometimes that work with the PCP, are involved. Many times, sometimes the PCP doesn't feel quite competent or doesn't take care of a lot of cancer patients, especially in the midst of therapy, and that's okay. And if that's okay, and that person wants to defer the care to someone else, whether that's in the center here, we've done that. That happens, but certainly a supportive team with the nurses often have a lot of influence on the primary care providers, and so I would encourage the nurses, and many times the patients end up talking to the nurses and telling them exactly what's going on, more so than with the physicians.
If I could add to that, one of the benefits of the physician portal that we talked about earlier in terms of access to medical record information to support that patient's care and follow-up, we've built in a feature that allows the primary care physician in the practice, once they register in the portal, to delegate access and authority to members of their practice staff. And that could be a nurse in their clinic, it could be the practice administrator, a referral specialist. But in the case of the nurses in the practice, that would give that individual direct access to that patient's medical record for ongoing care, just as if they were the primary care physician logging in. So depending on the practice and how they work, whether it's the physician or the nurse in the practice, we've made that easy for the clinical staff of the practice to get access to that information and again, maintain that timeliness and completeness and to be able to support that patient's ongoing care.
Thank you both so much. And Lyle, I think we'll stick with you as a question has come in regarding the portal.
Okay.
And it looks like it's a several-part question. Does MD Anderson evaluate PCP's experience in using the portal and in being involved with the patient's cancer care? And secondly, are physicians able to provide their feedback with the portal?
Yeah, great questions. In terms of the primary care physicians using the portal, we don't evaluate that way, if you will. Now, we track who's using the portal and what they do there. And just to give a little bit of a snapshot, it's very interesting being in a comprehensive cancer center that also has four, excuse me, what we call regional care centers out in the community. And what we see is for new cancer patients that are referred to MD Anderson, the main campus, about 25% of those are coming directly from primary care practices. So if you think back to the complexity of the referral equations between rural, community, and academic medical center, 25% coming from primary care, the main campus, but in our regional environment out in the community, that proportion goes up to 50%. So literally half of the new cancer patients in our regional environment are coming from primary care. Now, what I can't tell you off the top of my head is of the physicians using the portal, what percentage are primary care. I'd actually have to go back and look at that, but we could certainly get that data. I will venture that the proportions probably shake out closer to that 25% of the total users, because that in total is what we pretty much see in terms of referral activity. So that's sort of the metric and the who's using the portal from a physician standpoint. And I'm sorry, what was the second question?
Sure. Let me just look back up real quickly. And are physicians able to provide their feedback?
Oh, yes, yes. Actually, we've got several mechanisms where physicians can provide their feedback. Some of that's in person through our physician relations specialist team who actively go out and visit physicians in a fairly local area in their practices. We also do a number of physician survey types. We had done physician satisfaction survey where we got a tremendous amount of feedback about both access and clinical communications and follow-up, which actually drives most of the design of the physician portal. And then in an ongoing manner, we do have the ability for physicians who are in the portal to send us feedback via the secure message function direct into the Office of Physician Relations. So we're able to get that feedback on several levels, and we use that feedback in an ongoing manner to continuously improve the process. We're actually in the early stages of redeveloping the physician as well as the patient portal in conjunction with our electronic health record system implementation that begins next month.
And Lyle, there's also a question about the portal in terms of being proprietary, and if the portal has been shared with other oncology centers to promote communication between PCPs and oncologists.
At this point, the portal it's in-house developed software, if you will, and it's not software that can be installed on another computer. It's purely secure web-based access. Everything resides on servers here at the MD Anderson Cancer Center, but virtually any physician anywhere on the planet can go out to the web. The URL is my.mdanderson.org, and they can register as a physician user, and we'll verify that information for them, get that physician set up in our system, and they'll have their unique user ID and password, and from there they can invite members of their practice staff. So any physician anywhere in the country can use that. The only caveat to that is it's really a one-directional portal at this point in time, which means the physician who registers to use the portal has to go to the web, log in, and then they can either refer or access their patient's medical record. It's not shared software, if you will.
Okay, thank you. And this next question relates a bit back to that issue of communication that was talked about in the presentation. And how successful have you been in getting PCPs who use the portal to report back on the care that they're offering to MD Anderson patients? especially when that PCP may not be within the MD Anderson network?
Yeah, that's an absolutely wonderful question, and as part of the redevelopment process that we're thinking about is right now that capability does not exist within the portal. So if it's an issue of I've got a medical record or report that I wanted to send to MD Anderson, that has to be printed and mailed or faxed over to us. Internally, it gets scanned into the current EMR system so it's accessible by the Anderson faculty and staff. But right now, that type of health information exchange capability, if you will, doesn't exist in the current portal. The plans are that in the future redeveloped portal, which we're probably 2 to 3 years away, we will have that.
Great, thank you so much. Dr. Escalante, earlier in the presentation, you mentioned a case study in which the patient lived or had to travel, 2, 3, 4 hours between sites. And how does a patient who lives 150 miles away get to daily radiation treatments? Is there, what community-based resources might be out there?
Well, sometimes, depending on where they are from the center, we have in close to the main center, we have also regional centers, as Lyle mentioned, that offer radiation therapy. So they may not have to come all the way into Houston. We have 4 centers around the edges of MD Anderson of Houston in various suburbs. Now, if they live even farther, there could be another radiation center that our radiation oncologists feel comfortable referring that patient to, especially if they have a very difficult time getting any closer. So we work various arrangements. We may have a patient in New Mexico, and we have a radiation center in New Mexico that is part of MD Anderson. So they can go there if they wish and have an MD Anderson radiation oncologist do that for them.
Thanks so much. And next question, can you describe how you help connect patients to a medical home who may come to MD Anderson without an established relationship with the PCP in their community?
Well, we use our case managers and figure out, if I know a practice in that area that I've worked with before, it may be much easier. But if I don't, or if it's an area I'm totally unfamiliar with, we engage our case manager who helps to identify practices in that area. And again, it may be dependent on the patient's insurance or coverage as well as to whom they can be referred to. Or the patient sometimes may know of a practice that they would like to go to. And so our case manager can help in facilitating getting them an appointment and getting the records from here if they have not seen them before to that group.
Thanks so much. And also for you, Dr. Escalante, this question relates to actually a bit more of your current work there and not so much what we've talked about with this presentation, but can you tell us a little bit about the cancer-related fatigue clinic?
Oh, sure. We, a group of us, developed this clinic over 10 years ago because fatigue is the most common symptom in our patients, both those patients that are on active treatment as well as a subset of patients that are survivors and have completed treatment. We do a comprehensive assessment. Patients can be self-referred from outside if they have cancer or had cancer and have fatigue, or we get a lot of internal referrals from the other groups with patients with fatigue. We do a global assessment, including a group of symptom surveys, assessing other symptoms that may interfere with fatigue, such as pain, sleep dysfunction, other depression, anxiety, about 6 or 7 symptoms, as well as we do other total medical assessment, looking at other comorbidities, making sure there are not other issues such as anemia or hypothyroidism or uncontrolled kidney disease that could be influencing it. And we take a very detailed history and physical, looking at when did the fatigue begin, is there a pattern, what type of treatments they had, and a full physical exam, and look at laboratory if they haven't recently had to make sure that we're not missing something that may be easily reversible. Many times it's multifactorial issues, and we start working with the patient. Exercise has been shown to be a very evidence-based intervention that helps. We sometimes use stimulants where the evidence is not as good, and of course we try to correct other issues if there's depression or anxiety or other issues that may be influencing. We do have an article out on our clinic that was published a few years back, and I'd be happy to correspond if others have more specific issues related to the clinic.
Great, thank you so much. And that, I was just going to close out the Q&A, but someone else came in with a question. So for hospice patients, what can you do for decreased energy levels?
Well, some have tried steroids. We don't use steroids in patients that are not very near the end of life because of the side effects. But in patients that are very near end of life, sometimes steroids can help. I mean, and of course you want to manage the other symptoms that may be interfering with fatigue. So if sleep is an issue, trying to address whether it's, sleep hygiene, whether it's pain, treating the pain appropriately. If there's depression or anxiety, treating those appropriately. And as long as, depending on how functional they are, activity, I always try to keep patients as active as they can be. If getting out of bed and sitting in a chair is the most they can do, then I think that's fine. We should try to do that if they can do that.
Great, thanks so much. And it looks like that does wrap up the questions that have come in. Before we conclude, I do want to remind everyone that today's webinar will be posted to the PCPCC's website and can be accessed starting as early as tomorrow. And we otherwise just want to extend deep thanks to Dr. Escalante and to Lyle Green for taking time today to provide us with this information, and thank everyone for your time in joining us on today's webinar. So thank you so much and have a great rest of your day.
Thank you.
Thank you, Dana.
Bye.
Bye-bye.